we move to the next session. I thank all the experts and the discussants in this session to help us out. And the next session is on coronary imaging again. So we started the day with intravascular ultrasound, and now this is on OCT. So may I invite Dr. Nishit Chandra, Dr. Mamas, Dr. Rajneesh Kapoor, Dr. Ravindra Rao, and Dr. Ajit Mullasari. Hi. Hi. We'll start with Ajit's presentation, and I will also like to invite Dr. Pavan Suri, Dr. Pradeep Harnali, Dr. Anil Sharma, Dr. Rupesh George, Dr. Gaurav Minocha. Please join us on the discussion panel.
You're on the front. You're very well.
Can I have my slides up, please?
Yes.
Over to you, Ajit.
Yeah. Okay, we saw some great cases, and we saw Ashok presenting a very difficult case. And I'm going to go step by step how imaging could help you sometimes to prevent many of the problems which Ashok faced by starting off with a basic imaging with OCT. So here's a 71-year-old gentleman, ACS non-STEMI in the anterior territory, diabetic, hypertensive, moderate LV function, and a guideline-directed therapy. And you can see from the angiogram that there is a long lesion. You can see some calcification. I'm not sure whether you can notice that on the angiogram itself in the LAD, and the LAD is significant, please to note. So, and you can see that it's a very eccentric lesion. And what you do in sort of a scenario like this, the right is okay. It's a straightforward case. We do a pre-dilatation just to get your OCT in, just to get the OCT down the artery, and then you do a OCT pull back. Now, I just want you to see all these pictures, and this will tell you how to manage this patient. So we start with a level of, sorry?
There'll be a pointer here. So cursor. Your cursor.
Yeah, okay. Okay, so this is place. So, okay, so we're starting with A, and that's distal. You can see plaque here. You can see level B, where is the lesion. And you can see all calcium all around here, 270 degrees at level C. You see D, where is the tight part of the lesion. There is calcification, and the depth is pretty high. It's 1,000 micron here. Here you come to the level lower, and you can see clearly the lesion pre-dilated with a little bit of dissection, and then you come to the proximal vessel, and you get the proximal LAD lesion, also having plaque. So what it all tells you is the distal diameter is 2 square millimeter. There is 270 millimeter calcium all around the artery. There is a lesion which is tied just before that, and the proximal reference diameter is 2.83. So you got all this in your head. You got calcium, you got a 2 millimeter reference, you got 2.8 proximal. Your calcium length is about 17.2 millimeters. The length of the lesion from normal to normal is 48 millimeters. So this is all in your head. So what do you do next? So what is your plan? Before you start the procedure, get your plan ready. There is 180-degree calcium with more than 500 micron thickness, length more than 5 millimeter. Your calcium score on the scoring is 4 points. Hence, it needs preparation with some sort of debulking device. You can't go in with a balloon only. You have to debulk this lesion because it's a complex calcium, and you need to fix it. What sort of device will I use? This is eccentric calcium. I will not use a high pressure balloon. I will not use IVL because this is not concentric calcium. This is eccentric calcium. The balloon with IVL will not work because it will give the pulse on the wrong side and it could create a rupture of the balloon because of this PQ. Your diameter distal is 2. Your vessel tightest is about 1.3, 1.4. So my debulking device of choice will be a root ablator, which is 1.5. And then we could decide whether we need to know the next step. So this is how you think when you go in after an imaging. This basically is a nice paper in neurointervention about calcium scoring, just for your reference as to how you plan it. So you go with a 1.5 root ablator at 183,000, and we followed it up with a 2.5 angiosculpt because apart from the root ablator, there was fibrous disease. Remember, angiosculpt will not cut calcium. It's very, it's just got reeds around it, which will not cut deep calcium. You can cut fibrous tissue, you can get minor calcium, which is not going to cut. So you're going to use this 2.5 to just cut the other areas of the calcium. And then you follow it immediately. You don't end there and stop, say, okay, now I'll put my stent. You follow it up with another OCT. Now let me go through this OCT. So now as you see, your A level is 2.25. Your B level, you can see that the plaque is modified. You can see cuts here because of the root ablator. You can see multiple cuts here. You can see a cut here. You can see a cut here. You can see a cut here. And you can see the fibrous tissue which has been cut with the cutting balloon. And your proximal diameter is now 2.6. So what more information have I got? Yes, I've debulked. 2, I've got my cuts going. I've got my calcium fractures done. My distal diameter is 2 to 5. My proximal diameter is 2.6. And the EEL, which is commonly talked about, is not seen. And this is very common, that you don't see an EEL when you have badly diffusely diseased vessel. So you got to depend on the lumen now and not depend on an EEL. So what do my plan strategy 2 stay? How do I make my decision now? As the distal diameter is 2.25 and the proximal diameter is 2.6 and the EEL is not visible, I will use a device decided by the OCT automated measurement of mean distal lumen diameter and reference round it up to the nearest stent, which is 2.5 millimeters. That's quarter millimeter more. So you will use from 2.25, you'll use a 2.5 stent. That's a quarter millimeter upside stent. And for the proximal, because I was at 2.63, I could use another quarter millimeter. So it's going to be 2.75 when I get there. But what if I use one stent, which is 48, I'm going to use a 2.25, and you should know a stent which will go from a 2.5 stent which will go to at least 2.75, and if I need, go up to 3. So that's my plan. So we will get a stent which is 2.5. We will put it across with 48 millimeter length. Your calcium is out of the way. I don't need any other debulking device. And this is how you will plan your. This is a nice paper by Zaid Ali. We were part of this paper in neurointervention, how to size and how to make your decision of the stent. So here you put a 2.5 into 48 millimeter DES, and we post dilate with a 2.5. Well, people will say, why don't we just finish it off, put a 2.75? I think it's a 3 millimeter vessel. Why not? No. But when you have an OCT, why don't we have a look? And I think that's the most important thing to prevent, like what happened with a shock, a rupture. Oversizing diseased vessels with negative remodeling would create a problem. So what you need to do now is, again, take a measurement. Now, when you take this measurement, you first look, is there any dissection distally? There is no dissection. Then your distal dead stent, you check whether it's dilated well. It looks reasonable. You come proximal, and you can see minimum stent area is 2.85. We're not happy with that. And the proximal stent area, there's no dissection, 6.5. So obviously, your distal expansion, this is what the Illumin 4 is going to tell us. That Illumin 3 showed us that your distal stent approximation should be 90 to 95% of the distal area. We have got to 100%. Your distal stent, we've got up to 84%. And the proximal to the area here is 56%. So clearly you're underdone with this. So what do you do next? You go up with a 275 with 12, post-dilated at high pressure all through in the proximal and the mid segment of that stent, and then you pull back another OCT. And when you pull back the OCT, now you realize that after the post-dilatation, your minimum stent area is 3.15 distally, but it is 100% of the expansion of what is the distal area of the vessel. If you push this further, you're not going to get any benefit, you're going to get a complication. You come proximally here, the proximal stent edge is 6.7 here, it's 82%. Ideally, by Illumin, we should get to 90. We are still at 82%, which is not bad, but we should have got it to 90. Will I use a 3 millimeter? My answer is it's suspect. If I'm happy, if it's a round picture like this, there is no malopushing, there is no under expansion of the stent, your lumens are reasonable, I will back out if I think that by pushing another 3 millimeter balloon to try to achieve to 90, you may get a rupture. So this is, by Illumin criteria, distal stent well done, but proximal stent is about 8% underdone. But that's fine, because I've got a good reasonable lumen in the proximal LAD, and that's my final result. So this is how you use OCT-based decision in long calcified lesions. You help in what is your lumens, you help in what is your diameters, you help in your debulking strategy of what to do, what device to take, helps in correcting stent under expansion, achieve your stent lumen areas without complications. Thank you very much.
So that was a tremendous talk. Can anybody from the panel want to add something or want to say? Mamas, have you got any comments on this?
Yeah, I mean, I thought it was a really superb talk. You really covered, really state-of-the-art imaging. I think the most important part that the audience should take away is that OCT isn't just for post-PCI. It's crucial to do it up front, because actually that's where you get most of your information from, and that's what leads to the best outcomes, because you choose the appropriate strategy.
There's only one point that I may not agree with. And that's, I love the pre-part, I love the post-part of imaging. This bit about, okay, after plaque modification, am I going to look at it and what do I see? So I have two plaque modification tools. Rotational atherectomy, I do rotational atherectomy. Nothing predicts for me whether a balloon would dilate that lesion or not till I actually use a balloon to dilate it. And if I use IVL, we know from CAT data that it's only 50 to 60% of the patients in whom you see fractures and plaque cracks and fissures. The rest is modification due to softening of that calcium. So it doesn't tell me anything. What tells me more is that I put a near optimal size balloon into that vessel after that, go to high pressures, 1820, and if it gives way, I stent. So I don't see why image. I'd rather have a balloon there which expands and tells me that there's nothing more to be done than to faff around.
Sure, Ashok. I think there are the pluses and negatives of this, but I think at the end of the day, the whole procedure, and we use half saline with contrast, and I think in this patient we had about 30 ml more in this patient with 3 OCTs. So unless the patient has a problem with kidneys, you don't want to inject too much of dye. And today with HD-IVUS, this is an OCT presentation, but you can do all this with an HD-IVUS without injecting any dye. But my point here was you many times get away with what you do. But if you want to do this systematically and want to do it, take your time, make your decisions, don't be arbitrary in what you're deciding with balloons. And we saw with Illumin 4, we were part of Illumin 4, and we could try to get to 90% many of the times by being sure that your, if you don't see your EL, at least your lumen plus 0.25 plus 0.5 is not getting, disturbed. Because otherwise you'll land up with a rupture. And that's what you don't want to land up with on the CAT table.
So no, I was saying pre and post is vital. Pre will tell you the vessel sizing, pre will tell you the strategy, post will optimize it. But the intermediate step is still a vague thing to me. It doesn't tell me anything. But anyway, let's move on to the next one. So I think we need to go on to a case in a box, restenosis, best defined. Praveen, over to you.
Thank you, Dr. Seth, and everybody here sitting, enjoying this evening discussion on OCT and many other very, very important aspects. So I'm now moving to the restenosis, and although we still do not know what is the best recipe for treatment of restenosis still today, but we will like to see how we address restenosis. So we have to understand what are the issues related to that. So instant stenosis, as we all know, has, there are 3-4 types: focal, diffuse, beyond the stent, occlusive, and also there are now guidelines and consensus and as to how we approach restenosis treatment. And here is the the guidelines, and we it shows that DES or DEB. So DEB is also class 1 recommendation for treatment of instant restenosis, and in patients with of course recurrent episodes, intervention should not be done. CABG should also be considered, and imaging is also one of the major things which one should try and do, whether it is intravascular ultrasound or OCT. So either of the imaging should be done to understand what is happening in this patient. And there are 3 things which have come up after imaging is done. One is that this patient could be neointimal hyperplasia, as it is seen on OCT, which is a homogeneous uniform right area, or it could be new atherosclerosis. So new atherosclerosis is a reasonably new term for all of us, but now this is actually a term which has come from OCT imaging primarily, I think. And here what happens is that it is a necrotic core with a thin cap, lipid accumulation and calcification with macrophage infiltration. And typically it was described in bare metal stents after 1 year. So if a patient is coming after 1 year and he shows these kind of things, it is new atherosclerosis. But after DES, it can start earlier, because actually DES does this. It prevents neointimal proliferation and new atherosclerosis starts. So that is a little bit of concept of new atherosclerosis. And third, of course, it could be stent under expansion, because many times we undersize stents because we don't, as Ajit was saying, many times we don't image it and we size these stents based on the angiographic images. So these are various kind of images which we see. It could be a homogeneous instant restenosis, as you can see here, these pictures, or heterogeneous, attenuated, layered. Many kind of images can be seen in these patients, and many of these patients who have neoatherosclerosis can have thrombosis also, and plaque rupture, neointimal rupture of these plaques, and all this can be a very mixed bag of these pictures which we see in patients with instant restenosis. So how do we go ahead then? So once we identify, so we define what is the cause, what is the culprit here in this instant restenosis, assess the lesion, the length of this restenosis in various projections, then we start and decide what do we do. So most of the times we have to prepare the lesion vessel bed very well using high pressure balloons, cutting balloons or scoring balloons. We have now 3-4 types of scoring balloons, and address all these mechanical factors. And sometimes also we have to do a laser or maybe a shock wave if there is calcification additionally, and then go ahead with either DES or a drug-eluting balloon. And today, I think with so much of drug-coated balloon technology coming up, and it's already there, many patients, like 80% patients, are being treated by drug-coated balloons after vessel preparation by a laser or a cutting balloon. And then, of course, finally reassess how you have done doing a OCT or a intravascular ultrasound. So either of this can be done. This is one of the studies which is available from the Light Lab initiative, which was done in several centers. And here it was pre-PCI OCT to strategize, and post-PCI OCT to optimize, as already we discussed in the last presentation. And what happened in this study is that the impact of OCT was quite visible here, as you can see, and many times, about 25% times, ISR was not identified well on angio. And in this study, 50% times OCT added to a ISR mechanism over angio assessment and then led to change in the treatment strategy in these patients. And as you will see here, the treatment strategy changed in about 41% of patients in terms of vessel preparation, use of particular balloon like cutting balloon, atherectomy or laser, and then followed, once the OCT was done post, it showed that there was a betterment of the results after doing some alteration in the technique after the stent implantation or DEB. So here you can see that there is a difference in MSA pre and post intervention based on the OCT done in these patients. So basically, in this study, it did show that OCT or imaging does make an impact whenever you are treating in-stent restenosis. So at least 50% times it makes a difference. So let me just show you one or two cases, and this is one of the cases. As you can see here, a tight stenosis of the ostium of the circumflex. And I believe that this is one of the most difficult things to treat, especially if you have an in-stent restenosis of a large ostium of the circumflex. And here what we do. So in this patient, a laser was used, as you will see. The laser cutting was done, and in this figure, as you will see in this figure 4, after the laser cutting, a lot of tissue was removed, and following this, in this patient, a stent was done. But let me tell you, more than 70% times these days, we use drug-eluting balloons, especially if there is a lesion in the proximal part of the LEDs. There is some plaque sitting there, as it was in this patient. I would have left with just a drug-eluting balloon after this beautiful result with a laser and a cutting balloon. But in this patient, it was done earlier. But today, many patients we are treating with the laser, and there is data now which is coming up with laser. Although laser is a technology which has been there for a while, for many years, but now with the use of additional technology like cutting balloon or scoring balloon, it gives reasonably good results and almost stent-like results in patients with in-stent restenosis. This is a patient, again, who came with multiple, episodes of intervention in the past, and of course, this time again, he had a total occlusion of the right artery. There were 2 stents which were already there in the right artery. It was total occlusion. It was a Gaia 2 wire which we could, finally cross. And after that, we did a laser because none of the balloons was crossing. So we did a laser here with a 0.9 catheter with, I think, fluency of 60 and, rate of about 60 also because it was very tight. And after that, once the laser was done, we could achieve flows. We started dilating with the cutting balloon and then followed by the balloon dilatation going up to 3 millimeters in this vessel. And then we decided that in this patient, we will do a drug-eluting balloon. So we did 3 drug-eluting balloons, starting with a 2.25 30 millimeter balloon distally, and then followed by 2 more balloons in the proximal part. And finally, we got a very good result in this patient. So this patient's artery was looking like almost stent-like result, I must say. There was no major dissection, no flow-limiting dissection, and we left it with 3 drug-eluting balloons and cutting balloon and laser, getting good results. And this is one of the strategies which we use very commonly these days. The LED was in the same patient was also badly diseased, and you can see there was a large septal which was coming out. And this vessel was crossed with a specialty wire, and after that, we started dilating it. First, initially, we did a laser again because the same catheter you can use without any additional. It is not like the shock wave where you finish 80 pulses and you have to use another balloon. So this laser catheter can be used. And so we did the laser atherectomy again of this LED. And after that, we did a drug-eluting balloon in the proximal part. And in the middle part, also we did a drug-eluting balloon. And following that, we saw that there was some impediment in the flow of this septal. So we did a kissing balloon over here. And following that, we did a OCT to figure out how the proximal and the mid and distal vessels are. And we found that everything was looking quite good with just balloon dilatation of all these vessels with the drug-eluting balloon finally after the laser was done. So laser cutting balloon and drug-eluting balloons in these kind of bad long disease is quite helpful. Similarly, in many other cases like this, as for example here, in this patient, whether this is moving or not, I don't know.
Praveen, you'll have to finish up soon.
Okay. So we are almost, I am almost done here. So basically, all these cases showing that you have to use technology which is adaptable to this, like imaging, OCT or IVUS, doing a drug-eluting balloon instead of a drug-eluting stent preferably, and using atheroablative therapy like laser, rotablation, or cutting balloon. Thank you very much.
Thank you, Praveen. Those were extremely good cases, and truly the correct use of laser, apart from thrombotic lesions as well as uncrossable lesions. I think in-stent restenosis is a great indication. So, Ravinder, I think you have a comment or question?
I think great cases, sir. Just one question, sir. Can OCT help us to decide whether you want to use a DEB in an ISR or you want to put another stent?
I mean, basically OCT doesn't do that, in a very big way. The only thing is that some patients where you see that there is some haziness, you're not very sure, you want to do a DB or a DS, you can do a OCT and see if there is a large, dissection following that stent, or there is a proximal dissection or a flow limiting dissection, large flap moving around. In those cases, we have to put a stent, otherwise you can do a DB.
My question is a little extension of Ravinder's question. If it is neointimal hyperplasia or neoatherosclerosis, will it help us determine whether I'm going to stent it or I'm just going to do a DAB? Or is it possible that OCT may show dissection which is much more exaggerated than what it appears fluoroscopically? Will it interfere with our decision making?
Okay, so basically if you see a lot of fibrotic neointimal hyperplasia, in these cases definitely you have to use a cutting balloon or a atheroablative technique, because many times if you start using just a balloon, it will just jump out. It will melon seed like from sometimes proximally, sometimes distally. So unless until you do this, you will not be able to get a good result in these cases. And if it is a neointimal hyperplasia in new atherosclerotic lesion, so in these cases it may not be very necessary to use a cutting balloon or such kind of therapy where the balloon will not stay or will not expand the lesion well.
I think Praveen's got a point around the fact that in in-stent restenosis, there's a tissue ablation happening, followed by cutting balloon and DEB, and a combination of cutting balloon and DEB has been shown to be marginally superior to just balloon dilatation and DEB. So that's another important aspect of understanding, that this combination of threesome, which includes ablation of the tissue, perhaps even on OCT would give large lumens and would be fair to go for a final drug-eluting balloon without putting in long layers of metal, certainly in such situations, provided you get large lumens. I think that's the whole issue. You have to have large lumens.
And many times we have patients who have full metal jackets and they have restenosis. So in those cases, again, imaging helps, because if you do a good dilatation, you don't want to put another stent there or multiple stents in line. So then doing a drug-eluting balloon is quite a good experience in these cases.
You got to get lumens which are larger than the ones achieved at the first time.
Thank you.
I think with those comments, we could move on. Thank you, Praveen. Great cases. Coronary calcium. Viveka, over to you for coronary calcium.
Fortunately, we don't have a randomized trial with OCT in ISR, but I think we're just going by homogeneous and deciding. But I think the lumen is important and unnecessary metal is not required. That would be what we'll conclude now.
Yeah, so I think continuing with the same thing in OCT guided in calcified lesions, and I think Ajit has also clearly shown that it does help us in great way. We can classify whether the calcium is deep or superficial or nodular, and Dr. Seth has also mentioned that if you have nodular, you have you have different strategies, superficial, then obviously the different strategy, and the deep calcium, we have to have a different strategy. And also we can measure the calcium thickness based on that. So in this regard, the OCT has clear advantage over the IVUS, because you can see beyond the calcific area. You don't get blinded, as in this case you could see. So there is a scoring system also, which I think Ajit had already shown, and we can make a point by this we can always say whether the patient has got more than 180-degree arc of calcifications, the thickness is more than 0.5 millimeter, and also the length, whether it is more than 5 millimeter, and we give 1 point each, and the higher the number of points, the scores, the more the difficult the calcium is. Why do we care so much about the calcium? The reason being that there is a high risk of stent underexpansion, and that translates into all the adverse outcome, and also stent failure and the stent thrombosis. So acute and subacute adverse outcomes are more. And lesion preparation strategy also gets facilitated. How do we do a plaque modification, calcium fracture before the stenting is very important. And Ajit had also shown the images of OCT. So after doing the debulking, we can do an imaging whether the fracture has been there or not, and whether use of either lithotripsy balloon or atherectomy or laser or rotational atherectomy can be used in these. So in these, suspected calcified lesions should be assessed with OCT prior to stent implantation. So before imaging is also very, very important. And then lesion preparation can be guided by calcium classification and calcium score provided by the OCT. And OCT following lesion preparation allows recognition of calcium fracture and to determine if additional lesion morphology is necessary. So I think, there was a discussion whether pre and post stenting imaging is important, whether the middle is useless, but the incalcific lesion, the in between imaging is also very important to see whether you have done the job is adequate enough to put a stent for good long-term outcome. And OCT should be performed post-stent implantation, obviously to document the stent expansion and MSA, and also to look for any dissection. So there has been treatment algorithm based on these. So if you have got angiographic calcifications, if it is mild, non-atherectomy strategy should be taken. But if it is moderate or severe, then we need to do an imaging for sure, and then find out whether we need which kind of debulking, and atherectomy strategy has to be used in that. And this is again the similar kind of algorithm which was published in JCC, which again showed that we need to do imaging in moderate to severe calcification, and crossover also would be required. So we need to based on that, whether we need a rotational atherectomy, whether we need to do lithotripsy or laser, as Praveen has shown. All these things can be stratified with the help of the imaging. So again, the similar algorithm is showing that based on the scoring system, we can go for sometimes the rotational atherectomy, and after that also, if the calcium and the diameter is more, we might need additional equipments like IVL or so. So lithotripsy can be done. And also, as Ajit in one of his cases showed, that after rotational atherectomy, the cutting balloon or the scoring balloon would be used to further modify the plaque. So I'll show a couple of cases, which is, this is a patient who was 73-year-old gentleman who had, diabetic post-PCI, stent to RCA 10 years back, presented with, anginal pain, and his angiogram showed that the left main was normal, LAD was calcific, had 80% tandem lesions, diagonal was also diseased, circumflex was non-dominant, had minor plaquing, and right artery had 80% stenosis. So this patient had come from other city where the right coronary artery was treated, but despite rotational atherectomy, the lesion in the LAD did not open well, so they did not put stent and was sent to us. So we did try to balloon it further, and you can see that it did not open at all. So despite the rota of 1.5 bar, this is the undilatable lesion was there. So we did an OCT, and pre-OCT run, you can see that this was densely calcified, though the lumen was open, but it is, areas of significant residual stenosis were there. And obviously it needed bigger burr or, something more than that to expand the lesion. So you can see heavy dense calcifications were there, and after the diagonal and before the diagonal, the calcifications were significantly high. So you can see there was a calcium nodule also, and almost 360-degree arc of calcium was here in the PCI run. You could see MLA was 2.0, and proximal reference diameter was 3.31 millimeters. So here we did use a IVL balloon of 3.512 and was dilated, and the 4 therapies were given here. And you can see after the therapies we could see that this is the IVL therapy is going on, and after that with the OCT imaging we had an idea that the diameter is big, so we used a Zeiss stent 4x18 millimeter, and after that we did again the imaging, and you can see the post imaging also we did see that there was no distal or proximal dissection, and also the patient had the well expanded stent, MSA was good, and also the apposition was great. So based on this the imaging, we did the proximal post dilatation also with 4.5 millimeter to oppose the vessel at the ostial segment. So I think the imaging did help in patient who already had one episode, one attempt with rota and then failed expansion in other center. And since they did not have access to IVL, the patient had come to it was initial days of IVL. So this is another patient where, had proximal LED lesion significant, and there was heavily calcified, and the right artery was dominant but had mild plaquing and nothing significant. So here you can see that the fluoroscopically there was significant calcium, but the imaging had shown us that it is not a 360-degree or more than 180-degree calcification. So we thought that we could use the dilatation, and we can use the cutting balloon to modify the calcific plaques. So after we did an OCT to visualize the calcium. So this is the OCT run. You can see that there was calcifications. I'll just go to the in the interest of time. This is again a OCT run, and then we did a 3.25 23 millimeter drug eluting stents in the distal part, and then did again an OCT in that, and you can see the stent expansion was good. There was no dissection in there. So key takeaway is that with the imaging we can do the with the OCT you can quantify the calcium, you can strategize, and you can also use your debulking technique tool, and based on that the outcome can be good. And we should always, when heavily calcified segment, we should do a procedure OCT, then we should in between also post debulking we should do an OCT, and also after the stenting to optimize the stent outcome. So thank you very much for your kind attention.
Thank you. Thank you, Dr. Viveka. That was a very beautiful demonstration of the concepts around calcified lesion, the imaging, and the strategy around looking at those images and deciding the strategy. So could I have Nishit Chandra, your comments, and then we'll go across to Sharma?
So I think Viveka has very nicely summarized that the role of imaging cannot be overemphasized. In fact, with too many debulking devices now available, atherectomy, this rotablation, IVL, it is the OCT which can give us the good guidance that which debulking device upfront you have to use. So that is here OCT, irrespective of the lesion length, lesion size, OCT is more important for defining which debulking strategy you would be using it.
So Dr. Sharma, for
yeah, very wonderful talk. A quick comment about the OCT versus IVUS in calcium. OCT can wonderfully see calcium better than IVUS, there is no doubt. It can see edge to edge, it can see the depth. You need to learn the depth and deep are different things. But OCT cannot see beyond 2 millimeter. So like bigger arteries and even left main, IVUS is better, because IVUS is a sound base, which the wavelength of which is more than RBC, while in OCT, RBC has to be removed. So those lesions were very critical. We may require ballooning. So superficial calcium, better definition of calcium, OCT is better, while deep calcium, bigger arteries, IVUS may be better.
Dr. Mamas, your views on calcium and the modality of choice in imaging.
I mean, I'm an OCT user, so that's my strong preference. I guess for left main, that's where I differ. I generally tend to use IVUS. I think OCT is better because of the ability to judge the thickness of the calcium much more precisely, and that really helps me in deciding what my preferred therapy is for treating it. But also, it gives you other information. So I find that with OCT, I can see fractures within the calcium after I've rotablated much more easily than I can with IVUS, and that guides my decision thereafter whether I use a lithotripsy balloon in the areas that haven't fractured and are concentric.
Sure, absolutely agree with that. Like I said, apart from the fact of the left main, where only time will tell us whether the indices correlate with the outcomes on a longer term, is perhaps the only missing link which will fill in a few, hopefully in a year's time. And then we would be much more used to using IVUS for the left main, OCT for the left mains, apart from getting interesting pictures at the moment. So, okay. Yeah, so it's Ajit, of course, to make this comment.
Yeah, one area where OCT may be deceptive is when there is soft tissue before the calcium or a stent. And that will not penetrate deep, and you won't see the calcium or the stent. We had a recent meeting at ACBS Hyderabad where they did an OCT and said everything is good at the end of the procedure for the in-stent restenosis. And then they just did an HD IVUS, and the stent was under-deployed, and they had to go back and do this again. So one thing, remember that light requires to penetrate, otherwise you won't see the distal part. So be careful with that scenario.
Thank you, Vivek. So we now have Dr. Mamas talking about OCT in young ACS.
You've got the wrong talk. I've already done this one. So if you could change it. So it's a real privilege to follow the three illustrious speakers before me. I really learned the ECLA ablation in stent restenosis. So that's probably one of the first things I'm going to do when I get back to the UK and take some cool OCT images as well. I think that'll be really good. So over the next 10 minutes or so, I'm really going to try to change the talk slightly and try to persuade you that really you should be using intravascular imaging in every ACS case. And I'm going to really talk about an area that we don't talk about in meetings. We often, and in all the talks that we've had so far, we've talked about how OCT and IVUS can help you when you're going to stent. I'm going to show you 4 or 5 cases where in ACS cases, imaging helps you not stent, and where not stenting is the correct decision. And I think that's a really important take home, that IVUS or OCT is not just used for optimizing your PCI result, but also helping you make the decision of when not to stent in ACS cases. So doing PCI without imaging, in my view, is similar to driving with a blindfold on. You can't really always have a good result when you do this. And it doesn't really matter whether the rote is straight, so very simple cases, or whether it's a very tortuous lesion. Because actually, when you're driving, the most dangerous part is not the big boulder in the road. I mean, anyone can see that. It's the small little rocks that you can't see. It's the small things that you can't see on the angiogram. They're the ones that cause you the most problems. We know that intravascular imaging, both in the ACS situation and non-ACS situation, is associated with improved outcomes. This is data that we're all familiar with, reductions in cardiovascular death, AMIs, TLRs, stent thrombosis. We know this. This is data from randomized trials. Recently, EAPCI lent a consensus statement around when you should use intravascular imaging. And they gave a number of different indications, but one of the indications was in patients with acute coronary syndromes. And really, that's where my talk is going to focus on. They also said that there's less benefit in simpler lesions or in patients with stable clinical presentations. So this is a paper that will hopefully be published in the next month or so, where we've analysed every imaging case in the United Kingdom over 6 years. I think it's a couple of 100,000 imaging cases with PCI. And you can see we've stratified the patients according to whether imaging is indicated by EAPCI versus not indicated. And you can see that the main benefit is in the complex cases where it's indicated. You can also see that actually the biggest benefit is in left main PCI and in ACS. So again, an argument for using imaging in all ACS cases. So if we look at imaging in the UK in ACS cases, this is data that we've submitted for publication in JACC Intervention. Again, a 10-year analysis, even longer, 15 years analysis. You can see this in the UK currently. We're doing imaging in around 15% of cases, so still not enough, with a predominance more towards IVUS compared to OCT. This is data related to in-hospital outcomes, and you can see that irrespective of whether you use IVUS or OCT, whether you focus on STEMI or altogether, using imaging is associated with better outcomes. This is not highly selected cohorts, this is every PCI case undertaken in the UK over the last 15 years. Much better outcomes with imaging. Doesn't matter whether it's IVUS or OCT, use one, you'll have better outcomes, your patients will thank you for it. Now, the interesting thing about this data, this is the first time this has been shown in the literature, in the ACS, the biggest benefit is in left main and LAD lesions. So if, like in India and other parts of the country, even in the UK, where you don't get funding for intracoronary imaging, if you're going to use it for any cases, use it for LAD, use it for left main. That's where your big prognostic impact in ACS occurs. So this is the first time this has been shown in the literature. We're trying to publish it in JACC Interventions. We also know that imaging is associated with better outcomes from the ultimate trial, and we also know that it's not just doing imaging, it's acting on it. So this slide has already been shown. So this is, the next couple of cases are really trying to say to you, use imaging not to deploy a stent. So this is a case of a patient with an inferior STEMI who came in his 70s, smoker, whole lot of risk factors. This was his angiographic appearance. I undertook thrombectomy in the case. Lots of clot came out. And this is what I'm left with. So I ballooned, the lesion there, and not much change really. Many people would say, well, okay, you've ballooned it, just fix it, put a stent in there. I've shown it to my colleagues. They all said, yes, put a stent in there. Why are you imaging? Well, the reason I'm imaging is because when you do the IVUS of this case, you can see that the diameter is 9.2 millimeters. Even if you go more proximally, the diameter is around 7.5, 8 millimeters. So if you try to stent this, number one, you'll get probably no reflow. And number two, you're going to grossly undersize your stent. We don't have 9 millimeter stents. And so the way I treated this was not by stenting it, just ballooning to get TIMI-3 flow, give a NOAC for a week to dissolve the thrombus, and then medical management, and the patient did well. If I'd have stented this, I'd have probably put in a grossly undersized stent and had the risk of stent thrombosis potentially. Here's another case. This is a lady that came in with an ACS and with some anterior changes that you can see here. Now, this is an interesting case because this lady came in the day before, so she had a chest x-ray, and the chest x-ray showed a mass in her lungs. So she came in for a fine needle biopsy, CT guided. She went home that evening, developed chest pain, came in with these ECG changes. You can see nothing much in the LAD, maybe a bit of plaque there, and this lesion in the right coronary artery. So I asked my colleagues, what would you do when I did this case live? And they said, oh, we would fix this. It's a clear lesion, fix it. Well, that's the wrong mistake because I OCT'd, and actually, yes, she's got a chronic stable lesion in the right coronary artery. There's no plaque rupture event, and the changes were anterior anyway. This lady actually had a Takotsubo presentation because of a fine needle aspirate in her chest wall. It turned out that this lady had lung cancer. If I'd have stented this, that would have delayed her operation. Her LV recovered. A week later, she had lobectomy. She was treated with cisplatin and paclitaxel, remains well. If I'd have stented the right coronary artery, that would have been a disaster for her. So again, not a reason to stent using imaging. Now here's a case. Then I showed this on Twitter and everybody said, Professor Martin, why are you showing this case? This is a stupid case. It's a young guy, hepatitis B positive, who came in with anterior changes and ACS. I don't know why this is looking so funny, but anyway, you can see, he's got a lesion in his LAD. And most people said, Prof, why are you showing this? This is a straightforward PCI case. It's an anterior ST change, troponin elevated, his Hep B, fix it. And that's what most people would do. Again, I OCT in 100% of cases or image in 100% of cases. And this is the OCT. So this is the proximal vessel. And the first thing to say is that, you should be really suspicious when you have pristine looking coronary arteries proximally. This is at the level of the lesion. So this is a SCAD. So this patient had probably a vasculitis from his Hep B that had bled into the media, causing a SCAD presentation. And this is more distally. So this patient has a SCAD. So you've got a type A lesion. If you stent that, you've made a young patient who doesn't need a PCI have a stent. You probably toothpaste the hematoma and end up chasing it. So the correct treatment here, do nothing. If he's got ongoing pain or the flow is compromised, use a cutting balloon to release the hematoma. Again, all those were my cases. This I just got, rather than looking through my OCT library, I just got from a paper. And these are plaque erosions. We often see around 30% of ACS cases are actually plaque erosions. And I use OCT in many of my, or all of my ACS cases and find plaque erosions in many of them. And if they've got plaque erosion and they've got a good MLA, I leave it. I don't stent it. I just treat with antiplatelet therapy. We know from a number of studies now, erosion studies, that leaving these patients up to a year out have good outcomes, not at increased risk of ischemic events. This was the Erosion 3 trial, which they compared angio-guided versus OCT-guided. And what they found was that in OCT-guided, in cases where there wasn't a severe stenosis, you're far less likely to not stent these patients, particularly for plaque erosions. And you can see that the outcomes are not significantly different. So I think there's a lot of data now for plaque erosions with good MLAs. You don't need to stent those cases. Just treat with potent DAPT. And OCT data at follow-up up to a year out shows healing, and you've basically saved the patient a metal jacket. So I think in conclusion, intracoronary imaging should be used in every guideline indicated case of PCI, particularly in acute coronary syndromes. If your healthcare system doesn't allow that, then at least use it in LAD and left main lesions. That's where the greatest prognostic benefit is. I think the benefit of imaging is really derived from actioning information. Just putting an IVUS or an OCT catheter down a coronary artery doesn't magically change your prognosis. It's by doing something with the information that you find. I think importantly, in meetings such as this, the thing that we don't talk about is how imaging is useful to help you decide not to stent cases. That's a really, really important use of imaging. You can see that in the case I presented, the lung cancer case, the thrombotic case with a very large diameter lesion, the SCAD case, stenting would have caused harm to the patient. So imaging stopped me stenting those. And I'd say that most people in this room would have stented the type A lesion in the young guy, and most people in this room would have probably stented the right coronary artery in the lady. You wouldn't know that without imaging. I wasn't expecting that. I was expecting just to stent those cases. You shouldn't drive blindfold, therefore you shouldn't do PCI without imaging. Thank you.
Thank you, Dr. Mamas, for an absolutely wonderful presentation. I have to say that in India, 50% of young myocardial infarctions will be plaque erosions from what work we have.
Yes.
And many of the plaque ruptures will have good lumens. I think we need to differentiate pathophysiologically erosion from rupture.
Yes.
Unless there's a large rupture and occluding lumen, putting a scaffold like a metal would deemed to be unnecessary unless the flows are bad. And I think doing imaging, which is difficult in a STEMI situation, but useful in many of the lysed patients who come to India or a non-STEMI patient, would provide extremely important. Now the question is, once you do this and there's an erosion, do you do dual antiplatelet or do you do an anticoagulant with a single antiplatelet?
No, I generally do dual antiplatelet therapy in these cases. And I would disagree. I mean, for STEMI, I mean, we do primary PCI. We hardly do any thrombolysis in the UK. I think the figures last year, I think there was less than 10 patients having thrombolysis in the whole of the UK. It's the first time that it's been in single figures. And again, I do primary PCI all the time, and I do imaging in every single primary PCI, generally OCT. If there's heavy thrombus burden, I do thrombectomy to reduce the thrombus, then I do my OCT imaging, and it's useful information.
Yeah. Yeah, I think that's wonderful. But we have about 70 patients which we have used anticoagulant and single antiplatelet because it's all thrombus. And we feel, it's a very small number, that the OCTs at 6 months looks better in those group of patients. Maybe, we may have to go back to the older days where we used warfarin and aspirin rather than something else.
So, Pavan, any comments?
Yeah. So, any criteria,
observations?
sir? Which patient means all the patients should undergo imaging, or in younger patient, smoker, where there is a less risk of atherosclerosis, or like any role of calcium scoring, coronary calcium scoring?
I mean, look, I every case I do gets imaged. Every case I do gets imaged at the start, quite often in the middle, and always at the end. I agree that that's perhaps not feasible. That's not feasible in most places. I'm very fortunate to be able to do that. I would say that on the whole, any ACS, the greatest benefit that you will have are in calcified cases and in cases with ACS, particularly left main and LAD. That's what our data shows, which we've published and we're going to publish. So if you can only do it in a few cases, those are the cases, and young patients as well, because I think there you can save the patient from getting a stent, particularly if you show an erosion with a good MLA on OCT.
Thank you. My question to Dr. Mulasari and Dr. Ashok said, what is your practice? Younger patient particularly, no much risk factor except smoking.
So let me it's a very important question because I think the whole pathology is different in this group of patients. And I think there's a lot of erosion in these patients. 33% are smokers. We published that recently in Heart. We also feel that the patients who have plaque erosions with a lot of thrombus just needs medical treatment. In fact, the erosion too will start in India, in Indian patients in the next month. So that would be a very good important study to see. Finally, your question of calcium scores is completely irrelevant in young patients because you need time to build calcium. Calcium scores are good above the age of 60. Below the age of 60, calcium scores have no relevance. And below 45, if you look at the JACC weekly review last week, the only thing which works is history, ASCVD risk scores, and a polygenic risk score. No CT for these patients who are young.
So I feel this is a very nice, presentation as far as the OCT in the young patients is concerned, and especially in Indian scenario where we are finding the young MI patients, and we can find the non-coronary, non-atherosclerotic causes of the acute MI. This is very important in our scenario. But I have a simple question. For example, we have seen the two cases where one was the vasculitis where the hematoma was there, and the second case, in such scenarios, what goes against putting the stent in the case because the patient had an angiographically, it was a very tight lesion.
So, that's for you to respond to.
Yeah, I mean, so you shouldn't stent those cases. They have TIMI3 flow, and by putting a stent in, all you're going to do is compress the hematoma and toothpaste it forwards. And so what you're going to end up doing is putting repeated stents and end up with a full metal jacket in a young patient who doesn't need a stent. If you've got compromise of flow in these sorts of situations, I use a cutting balloon to release the hematoma and then do regular POBA. And in most cases, that settles it. Now, there are some cases that you do end up having to stent in SCAD, but I try to avoid it because most of these on serial CT scan shows resolution of the hematoma. And when you do repeat cath, say in a couple of weeks' time, a couple of months' time, you'll actually find difficulty in seeing where that lesion was.
Was the LED lesion, which was stented very well with a 3.528 drug-eluting stent in 2013. 5 years down the line, he came back with an NSTMI, and this was the angio. So what are you seeing on the angio? If you see carefully, does the angiography give you complete picture? Are you able to decide on the basis of angiography what would you do? If you see carefully, there is a filling defect at the proximal margin of the stent, which was put 5 years ago. In the cranial projection, you can see there is a blob, or the filling defect of blob. So what should we do now? There is a patient gentleman presented 5 years down the line with an NSTMI, ACS, and with the ambiguous lesion in the coronaries. To solve this problem, we did the OCT and we found there is a clot. But why a clot should appear 5 years down the line? Was the stent undersized? Was there a malposition or any other reason? So we did the OCT, and to our surprise, the stent was very well placed. There was no malposition, there was no undersizing, it was not underexpanded either. So what could be the cause of thrombosis 5 years? And the patient was taking DAPT. He took DAPT for a year and then followed by single antiplatelet. So if you see the fly through, the stent is well expanded and there is a blob of thrombus sitting at the proximal margin of the stent. So the answer to our question was also given by the OCT because of its good resolution. We based on the OCT, because we had nothing to do, we don't have to put another stent. We don't treat thrombus with a stent. The stent is well expanded. There's no point of over expanding also. So we just put the patient on GP2B and heparin, and we then brought him back only after 5 days. And after 5 days of antiplatelets and antithrombotics, you see the pristine looking arteries and the thrombus vanished. And we could save another metal jacket in that patient. So what was the reason after 5 years? You can see that some of the struts are still unendothelialized. So this could be the reason. You can see clearly that even 5 years down the line, the struts were not fully endothelialized. So this could be the plausible reason for the stent thrombosis in this patient. So another patient is a 55-year-old lady who came with classical history of chest pain and STMI and this angiography. So based on this angiography, is it clear? Would you put a stent? This is a borderline lesion. You will be accused of putting more stents. So, but the patient presented with an STMI. So what did we do? And here also the OCT came to our rescue. In fact, and when we did the OCT, this was the picture. There is a classical ruptured plaque with thin cap fibroathyroma, lot of lipidic plaque. So we covered it with adequate sized 4 mm stent with good expansion and no proximal edge dissection. So this ambiguity of coronaries was solved by putting a stent. So it also decides where to put the stent, not to leave it. So as Dr. Mamas has clearly emphasized that it is in the ACS scenario where it is very important to do an imaging. And this is the scenario where it is people hesitate because of the urgency that it will take time to revascularize and patient is unstable, so I should not be doing it. But it is in the ACS scenario where it is very important to describe the cause of that ACS. When you, in the ACS scenario, you may find normal coronaries or obstructive CAD. In the normal coronaries, the pathway is simple. You don't have to do anything. But if there is an obstructive CAD and there is a clear culprit, you have to stent it. But it is in the ambiguous scenario where you have to take help of intracoronary imaging, specifically the high resolution OCT. This is one scenario where IVUS is not of much help because it cannot differentiate between a plaque erosion where you have to leave you don't have to stent if the MLA is good, versus plaque rupture where you have to put a stent. So OCT is the imaging modality of choice in ACS patients. To illustrate the erosion point, Dr. Mamas has shown some pictures of erosion. I am showing you a very simple case which we've got in a COVID era. A 24 years old young boy who came with clear history of chest pain, 24 hours duration with significant ST changes. Echo did not show much wall motion abnormalities and a normal ejection fraction. Troponins were mildly positive. He was just 24 years. So we resisted the temptation to take him straight to the cath lab. We instead did a CT angio, and to our surprise, we found a filling defect in the proximal LAD. So this was with this CT angio report, we then took him to the cath lab, and we found the pristine looking RCA corresponding to his age. And you can see there is a filling defect in the proximal LAD, which corresponded to the CT findings. So he's just 27 years old. We did the imaging here. And what we found was a classical plaque erosion. This is the classical plaque erosion, no necrotic core, no rupture. So this patient was also saved by the metal of a metal jacket of a stent. We just put him on antithrombotic, brought him back, and the results were excellent. So ladies and gentlemen, I'll finish my talk with this algorithm and the emphasis that as an interventional cardiologist, you must know where not to put a stent. And angiography is not the investigation of choice to make a decision. It is the imaging, and especially the OCT with 10 microns resolution, which makes a difference between erosion, rupture, or calcified nodule. The only three etiologies are ACS. So no more excuses. Angiography has limitations. The benefits of intravascular imaging on PCI are irrefutable. There are trials, registries, meta-analysis in favor of OCT and imaging showing the evidence in favor. And choice of imaging modality basically depends upon the lesion and the question you need to answer. In ACS, it's the OCT, which is for left main. It is IVUS, which is more important. The gentleman asked a question that should we do OCT in all the ACS cases? Mamas, in his concluding remarks, told us in all the ACS cases, we should do OCT, but our socioeconomic strata will not permit that. So which cases in India we should be doing imaging in ACS? All those presentations which are unusual presentation of ACS, young patient, that way, young MI patient, 24 years, young females could be SCAT patients. Wherever you are not getting an adequate history or you're not getting to the cause of the case, these are the patient, they are mandatory to do OCT. And the rest of the patient, you can take your own clinical judgment and decide whether to do or not. Thank you very much.
Thank you very much, Nishit. We're at the end of the day, but we certainly could have comments and concluding remarks. So we could have Sharma, Ravinder.
Quick question. So in
of course,
patient ACS acute MI,
Ajit would be the last word.
Should we aspirate and do OCT, then decide?
So very, very good question, because for OCT, you have to make the region clear of the blood, because the light does not penetrate blood. So if there is a thrombus, you have to first suck it out, get a reasonable flow, and only then run your OCT catheter. Otherwise, you won't get any fruitful image. So you have to first suck out the thrombus.
Very educational talk, sir. We all learned about OCT, and I think we'll all start doing it in young ACS and patients, which you rightly pointed out.
Pradeep, what about you?
Very, very educative talk, especially the summarizing points, like where exactly can you consider OCT when you have constraints of economic constraints, more so among young individuals, women, or where you have specific risk factors. In one of presentations, like a Hep B positive patient, where they were suspecting an alternate etiology than the atherosclerosis leading to an ACS.
Thank you. Thank you. And Ajit, your final words. I clearly sense I think the message was correct, and Dr. Mamas gave a great message. ACS is one of the most important arenas for imaging to understand the pathology and to decide about its management, more so than any other scenarios, primarily because these could be very unusual. And I think that's what finally Nishit summarized. If you can't do them in all because of financial and reimbursement constraints, then certainly do those in the unusual presentations, because those are the ones where you really need to define and really need to strategize. And clearly demonstrating the fact that stent's not the answer to these patients in most instances has been one of the fruitful discussions of today.
One final question, like when
yeah, please.
OCT and an
I'm in fact happy you're asking question, because at 7:30 in the evening after a heavy day, if you still have that interest, I think we should be really here to answer those.
Yeah, so when you're doing an OCT in an ACS setting, because of diffuse sympathetic overactivity, many a times the vessel is undersized. And no matter how much you may flood the bed with nitroglycerin and nicoram, still you may not get the correct size on OCT when you need to stent the vessel. So how do you go about sizing the vessel on the basis of OCT in the setting of ACS?
So as a general rule, before passing any hardware, we have to give liberal dose of vasodilators. And with nitroglycerin and nicorandil, you are able to dilate the vessels to their original size. And I have not found that with the adequate liberal doses of nitroglycerin, we are not able to. Most of the time, we are successful in that. It's basically if there is a thrombus present, and then you have to be very careful of sizing, because if you have put a stent, there was an underlying thrombus between the lumen, thrombus resolves, there will be late malapposition.
So I think what we have to go back is ACS is the typical workhorse triad. It's got thrombus, it's got inflammation, and it's got a lesion. So unless or stenosis. We in the stent are only treating stenosis. We're not treating inflammation. We're not treating flow or thrombus. Now, this has to be particularly kept in mind in ACS scenario, where we should decide whether to put, to a man with a hammer, everything looks like a nail and you can't put a stent in. So the important thing is to differentiate these patients. And more evidence is suggesting that even with plaque rupture, if your lumen is good, maybe you don't need a stent. Erosion, no question. But remember, erosions is sometimes difficult to pick up in an acute scenario because it's a diagnosis of exclusion. You don't see sometimes behind the thrombus what's going on. And like he treated the patient medically and then brought him back, did an angiogram, and then checked and found that there was no rupture. That's the only way we can say it. Sometimes minor plaque ruptures can happen behind the thrombus and you may not see in the first OCT. But the most important thing is lumen. And it's very, very important that you don't stent. And COVID has shown that very clearly. Those who didn't believe in thrombus and inflammation, no lesion, you get thrombus all over the place, in coronaries, in veins, in cerebral circulation, and it's important that you differentiate these and don't put stents everywhere. Thank you.
Yeah, with those words, I think we come to the end of the day. Don't put stents everywhere is the message. Thank you very much. Thank you.